morning to everybody. Well, we're going to talk a little bit about otosclerosis from the lab to the clinical set. Well, Robert used to show these things, and I would like to show the real life here. So there is an easy task. Please find the clown here. I think you can find the clown right in the middle of my legs here. That's real life, no? So, well, but it has been a splendid friendship for many years now, and I'm really proud to be here. Otosclerosis is a primary metabolic dystrophy of the capsule otic, and it's exclusive in humans, and the trademark is the fixation of the stapes. But sometimes you have a cochlear involvement, sometimes pure cochlear involvement, and there is a clear genetic predisposition for otosclerosis. So the whole action is in the petrous part of the temporal bone. And what makes the otic capsule so special and unique? Well, inner ear attains full size and differentiation at midterm. And also, the ossified capsule, otic capsule and the rigid encased inner ear can grow no further after the 26th week of gestational life. So only a small fissure that will stay as a cartilage with connective tissue will stand from the vestibule to the middle ear. This small fissure was named by Selaimen as the fissula antifenestram that you can see right here. So if you have a newborn and you have the leg bone from a newborn and the otic capsule and you follow it through life, it grows, and the capsule otic will stay the same size. So it's completely different from other bones from the body. And another thing is that you have a fracture in your leg, you have a bony callus and then a complete cure of this fracture. But if you have the same thing with the otic capsule, you only have a fibrous capsule, callus here, and there is no ossification at all, because it's a different bone. Right? And why this primitive endochondral labyrinthine capsule persists and changes? What's the reasons? Well, to maintain the configuration of the inner ear, especially the cochlea and, of course, the lateral and the other semicircular canals. And the unchanged capsule protects the inner ear fluids that bath the hair cells from contamination from these bony enzymes that would be pretty much ototoxic. So this is the temporal bone, and especially the petrous portion of the temporal bone that is of our interest. A little bit of history. You know that Valsalva was the first one to describe the ankylosis of the otic capsule in 1741. And then von Troche created the term otosclerosis. And Adam Politzer described perfectly the histopathological profile of otosclerosis. If you go to the surgery, you have the Surdil surgery of the multi-stage fenestration, and then Lampert brought the fenestration to the state of art. In 53, Rosen reintroduced the stapes mobilizations, and then in 56, as we said yesterday, John Shee described the first stapedectomy. Here's one of the first movies made with otosclerosis surgery. You can see it very different from now. Well, there is a 10% global prevalence of histological otosclerosis, but only a 1% clinical prevalence. And why we have this difference? Because I'm going to show you a little bit later, but there are some good reasons for such. As I said, the basic problem is osteodystrophy of the otic capsule, and there is a resorption and new bone formation, and there is triggers, maybe hereditability, endocrine, metabolic, infection. There are many triggers that they are studied in the otosclerosis process. Well, to understand otosclerosis, you need to understand a little bit of temporal bone histopathology. And we have studied temporal bone histopathology in this lab of the University of Minnesota since many years. And I would like to share with you some of the things that I think it's important to understand the pathology of otosclerosis. This is back in 1989, and 2014. You know, I was younger, but here I have better companies. So to understand, I will show you a small tutorial of temporal bone histoanatomy. I hope you enjoy it. So sometimes these images, it's like a puzzle for us. So we have to put all these pieces together and try to understand these new images for the new young. Of course, some of you understand it pretty well. So let's take this section, this axial section of the temporal bone. We have the sternal-auditory canal, the middle ear, and the inner ear, and the umbo of the malleus here. And here, the annulus, one side and the other side. The carotid artery and the facial nerve. If you go a little bit down, then you're going to have here the oval window niche, the cochleariform process. Go a little bit down. Again, the niche, the sacral here, the facial nerve, the round window niche, the ampulla of the posterior canal, the sinus tympani, the the facial nerve, and the facial recess here. And you go to this place, you're going to see here the vestibular aqueduct, the endolymphatic duct. It's very important here, you can see the malleus and the incus, and surrounded by nothing, only air. I will come back to this later. And the facial nerve, the ampulla of the superior canal, the cochlea, basal turn, the Pils bar, you know, with the facial nerve and the superior vestibular nerve here, and some other things. Here, the anterior malleolar ligament, I think it's important, we'll see it later. The cochleariform process and the relationship with the facial nerve. And down to the posterior canal and the vestibular aqueduct. You'll see it again later. So let's move on. The pathology of otosclerosis has been described by Selaimen, and there is a histological profile with otospongiotic bone, that the real name of the disease is actually otospongiosis and not otosclerosis. And it's generally limited to the anterior margin of the footplate, the region that I just mentioned, you know, the fistula antifenestrum. So there are two phases of the disease. The active phase is the otospongiosis, where you're going to have active bone deresorption and vascular dilatation with the Schwartz sign. And the mature otosclerosis with deposition of new layers of bone. So the bone is much more denser there. Here we have very immature otosclerosis around the cochlea and the oval window. And here, a dense bone. So here is the otosclerosis phase of the process. Here you can see the difference between the normal bone here and the otosclerotic bone with vascular channels here. As the lesion expands through vascular channels, the tissue, it shows an increased affinity for ametoxylin, making the bone appear darker in this area. They call it the blue mantles of Manas. Manas was the first orthopathologist, Paul Manas, and those are the blue mantles. You know, it's the advance in front of the otosclerosis is darker. This is the blue mantle. For us, from Porto Alegre, the real holy blue mantle is the Grêmio shirt. You know? This is our blue mantle. Contra Colorado, always nice. Let's see something that is very interesting. The difference between histological and clinical otosclerosis that you can see in the next slides. Here we have a focus of otosclerosis right in front of the footplate. But if you blow it up, you're going to see that the ligament is free of disease. So you have histological but not clinical otosclerosis in this case. Here is the same. You have a focus of otosclerosis right here, but the ligament is free. So probably this footplate is still mobile. Here we have a focus and the footplate involved, but almost they are not touching each other. Maybe this patient has a pretty good hearing. Differently from this one, that we have a focus involving the anterior margin of the window and the anterior crura. So this is a clinical otosclerosis, histological and clinical otosclerosis. There's a difference. So if you go, there's histological otosclerosis is the facial nerve. Clinical otosclerosis only in the fenestra, we call it fenestral otosclerosis. You move again, the fenestra, very otospongitic bone here, very active focus of otosclerosis. There is one here and another one here. Then we have here the fenestral otosclerosis, but also cochlear otosclerosis with distortion of the silhouette of the cochlea. Again, huge focus of otosclerosis around the cochlea and the windows. And sometimes you can have pure cochlear otosclerosis. There is a big discussion about that, but Selaimen describes for the first time a focus compromising only the cochlea and suggests that otosclerosis may cause sensory neurohearing loss through different mechanisms. So we have here pure cochlear otosclerosis distorting the anatomy of the apical turn here, and also with endolymphatic eye drops here. Probably there is association here of otosclerosis and Meniere's disease, in this case, syndrome. So what happened is the focus of otosclerosis, we're going to involve the spiral ligament and maybe the stria vascularis, creating conditions so to generate pure sensory hearing loss. So when you have to think about otosclerosis in a patient with pure sensory hearing loss, when there is a good speech discrimination, when there is a positive family in a patient with symmetrical hearing loss, and of course when you have also a positive Schwartz sign. So think about otosclerosis. Some of the non-believers that you can have the pure cochlear otosclerosis, they say that if the focus starts in the fistula antifenestra, it grows concentrically to attach and to attack the cochlea. In the other way, you will have to fix the stapes. So you need the conductive element of the disease. There's a big discussion about that. What's the most common sites of involvement of otosclerosis? The fistula antifenestra, as we said, but also the round window niche involvement. This is a obliterative in the round window niche. Here, and also here. You have the middle turn of the cochlea sometimes involved. And we have the posterior margin of the oval window like here. And also the anterior wall of the internal auditory canal, around the cochlear aqueduct, and also the semicircular canal. So there are possible sites of involvement of otosclerosis. And sometimes you have otosclerosis all over the place. Like you can see a cochlea here, but only with an acute eye. So what's the clinical profile? Everybody knows that. You know, a woman, conductive or missing hearing loss, mostly bilateral. In the audiological profile of otosclerosis, excellent bone conduction, conductive loss, Carhart notch, absence reflex, and good discrimination. This is typical. What are differential diagnoses of otosclerosis? We have many diseases that can make confusion with otosclerosis. We're going to see some of them real quick. So one of them that have been mentioned today is the fixation of the malleus head to the lateral wall of the attic, like in here. That's what I show you the first image. So you can see here the malleus and the incus, but there is a bone bridge between the malleus and the lateral wall of the attic, right here. So this is absolutely different from this situation when, you know, both the malleus and the incus are floating by themselves in the epitympanic space. Here we have a connection between the head of the malleus and the lateral wall of the attic. So that's so important to do that maneuver when Robert showed, when after this articulation, try to move the block malleus and incus to see if it's mobile. And he had already talked about this study. Sometimes you have ossicular disjunction. You think that it's otosclerosis, that's not. Unilateral, probably with a trauma. In this case, with ossicular disjunction, you know, the audiological checklist will show you the maximum air-bone gap. You know, it's a really huge back with an intact tympanic membrane. And also with good discrimination. This is a very interesting case, a guy that had a blow in the head and with a fracture of both crura of the stapes. Robert Van Seur showed a case yesterday. We did a stape surgery here, you know, with not opening the oval window and putting a Teflon prosthesis straight from the incus to the oval window niche. And this patient had first a very good hearing result, and he has been like that so far. Here's another very interesting case with a doctor that was scuba diving and had a popping sensation in the ear and came to my attention with a small conductive hearing loss. I will show you. And later on, I did a CT scan, and he had a fracture of the malleus handle. As the hearing loss wasn't so big, I didn't do anything. So I would like to discuss this case with you guys to give me some ideas here. But it is another differential diagnosis. Again, a very important one is tympanosclerosis. And there are two types of tympanosclerosis. The one that we'll see only in the tympanic membrane, that's very superficial, and one aggressive, what they call osteoclastic mucoperiostitis, that invade the middle ear cleft and fix the ossicles. Sometimes it's really difficult. Maybe it's the worst situation that we can face. When it's only in the tympanic membrane, we have done studies, and the focal of otosclerosis, the bigger the loss. And maybe because it decreased the vibrant surface of the tympanic membrane, or bigger the plaque, greater the chance of middle ear concomitant involvement. So sometimes you have only a small plaque of tympanosclerosis, as the case that you showed yesterday, Thibault, your case. But minor plaques and major repercussion. You see, there's it's attached to the lateral wall through the tympanosclerosis plaque. Like in this case here, the promontory is covered with tympanosclerosis. It's really bad to clear up this tympanosclerosis, and sometimes you cannot tell what is tympanosclerosis, what's the oval window, what is the facial nerve. So it's a very delicate situation. And you have to study it pretty well. There's another new diagnosis, the dehiscence of the superior semicircular canal. It was described in 1998 by Minor. Probably Doug know this guy. I met him years ago. And there is, along with the kind of autophony and aurophones, there is hyperacusis, pulsatile tinnitus, and sometimes these patients, they improve the symptoms when in supine. And they also have the perception of the muscular movements. And you see, there is a checklist here, very good bone conduction in low frequencies. There is a conductive component in the low frequencies, a mixed hearing loss in the high frequencies, and also the Carhart notch in these patients. Of course, they have present reflexes, so you have to think about them when making your differential diagnosis. Another one is enlarged vestibular aqueduct. It's not so common, and also, it's hard to make a confusion between this kind of situation and otosclerosis. Anyway, these patients, they will show, and that's why I show you the posterior canal and the vestibular aqueduct, and you see there is the proportion that's completely different here. You have that really huge vestibular aqueduct in comparison with the posterior canal. So these patients will display sensory neural or mixed hearing loss and a conductive component in the low frequencies. And of course, this is generated by the third window phenomenon. And you see, to think about these guys, you have to think about the clinical history extending to childhood. They will bring this complaint since childhood. There is a mixed hearing loss in patients without family stories of otosclerosis. And the CT, this is key, will show a vestibular aqueduct enlargement with a diameter equal or even greater than the posterior semicircular canal. This is a very good issue here, is the alienization of the anterior malleolar ligament, this ligament here. And Hugo Fisch, it's really firm in this situation, and he's changed his approach to otosclerosis and is doing the primary malleostapedectomy in 20% of his cases to manage what he thinks is almost universal in otosclerosis. It's a lot of debate about that, and the group from the University of Minnesota has done a splendid histological work, and they have shown no evidence that this alienization occurs in patients with otosclerosis in a different way than in normal. So something that we have to discuss with Professor Fisch. Paget and osteogenesis imperfecta. We have to think about that too. I don't know how I am, my time in here. It's okay, so 5 minutes? All right. So the fact, that's very important, that clinical picture of otosclerosis has been well established for years, and the diagnosis is simple. No? It has not prevented the development of new and powerful diagnostic and therapeutic tools. The main important maybe is the CT scan, as we have discussed this morning. So why the CT can help? Well, there are studies showing that the sensibility of the new CT scan is 90%, and the specificity is close to 100%. So it's a quite interesting tool. And they have shown that only the bad results are extremely tiny focus, that they can be singled out by the CT scan, and it's very erratic, the CT scan, when analyzing the endosteal margins. So this kind of focus here, maybe the CT scan will not show you. But it's important, the CT scan, to measure the extension of otosclerosis focus, to make a correlation with the hearing thresholds, to anticipate difficult problems during the surgery, especially the obliterative focus or the other things that we just have discussed, and of course to evaluate post-operative complications. So take a look at these images. I did a superposition of a CT scan and a temporal bone slide. So you can see here we have a very bad focus on the window, and you have the temporal bone, a very, very bad focus on the window. You go to another case, you're going to have here, you know, the anterior margin of the oval window and a part of the cochlea involved on the CT scan, and here we have, you know, the histological sections showing the same place with the otosclerotic focus. Again, here we're going to have a involvement around the round window niche, and here we have a very bad focus of otosclerosis around the round window niche. So it's very important, the CT scan, and can help you a lot during the pre-op diagnosis and planning of the surgery. MRI? When MRI? Well, to study the cochlear patency in the case of far advanced otosclerosis may be helpful, and also to investigate post-operative inflammatory complications of staph surgery. So we can use the MRI, it's very good, but we don't use it in our routine in basic cases. Some fast pointers and pitfalls during the surgery. You know, the otosclerosis surgery is pretty simple. You remove the stapes, you open up a small opening in the foot plate, and then you put the prosthesis right there, right? But I tell you, it's smoothly like this only here in this house. You know, it's not so easy when you go out and try to do this kind of things, right? So we have problems. And what kind of problems? The first one is the facial nerve. So you have the facial nerve here, it's okay, no problems with the facial nerve. But here, you have a facial nerve that is dehiscent, but it's not prolapsed into the window. So that's fine, no problems. But here, we have a facial nerve that is prolapsed, but not dehiscent. And here, we have a facial nerve that is dehiscent and prolapsed to the oval window. So we have all kinds of situations, and you can study that perfectly with the CT scan in the preoperative period. See? Sometimes, and here, it's even worse. You have the obliterative focus and sitting over it, the facial nerve. Oh, that will be really a bad thing here. So in these situations, we have to get smart. You have to deal nicely with your facial nerve, and if it's dehiscent, like here, then you may get into trouble. So we have to get smart. You cannot sleep. You have to get smart, otherwise you go to jail. And not only you, but your whole troop will go to the Béziers jail, you know, the whole guys, you know, in this dirty situation. There's another situation, is the dehiscent facial nerve here. During the surgery, it's not so bad, and it can be managed with care, not to offending very much the facial nerve. The persistence of the stapedial artery, it's a possibility, it's not very common, and the stapedial artery is a real artery. You can see here, you know, the stapes, here is the crura, and the real artery that can really be bothersome. Here we have a case with chronic otitis media and the artery. I never faced the artery during the stape surgery. Round window obliteration, you know, 1% then can be completely obliterative in hearing loss. Only will happen when 100% is obliterated. So it's a very difficult situation. Here again, and here is a really bad situation. A biscuit foot plate, you can see in here. It's only to orient yourselves. You have the facial nerve here and the fistula antifenestra here. And obliterative otosclerosis, again, you see, this is a case that I think it's from Wilco, this case. You can see the foot plate here really, really thick. The floating foot plate is another problem. Guys, we'll talk about that. The gusher, they have already mentioned, when you have a patent cochlear aqueduct. This, I think, belongs to Wilco, this case, I'm not quite sure. Let's move. Erosion of the lung process of the incus, like in this case here. This is my own case, you know, it's my revision. When I remove this procedure, you can see there is a sulcus over the lung process of the incus. See, we're going to remove. So you have to be prepared here with all kinds of prostheses, because I had, in this situation, only Teflon prostheses. I don't know if it would be the best situation or not. I'm done. All right, I'm finishing. Faulty technique, you see the foot plate here, and the prosthesis is touching there, but not entering the inner ear. Here, another prosthesis that's leaning in the oval window, but not going into the inner ear. Here we have one prosthesis and two prostheses. Already a bad situation. And that's the last case I'm going to show you guys. There is a possibility of Meniere's disease and otosclerosis. And sometimes when you poke the foot plate, you can poke the sacral if it's dilated. So this is not a big deal. But you see only the normal sac here. It's here, and then you have the sac with invasion of otosclerosis focal. And sometimes you go through the window, you need to take care, go the most 0.5 millimeters inside the inner ear and take care with the sacral here. Sometimes you can move the foot plate inside the vestibule. This is bad. I'll show you the last case. This patient with this hearing loss, she did a staph surgery, had a pretty good hearing result, but had positional vertigo and refractory to vestibular suppressants and maneuvers. And this patient had, as you can see, the whole stapes inside the vestibule. It's incredible that the hearing was so good, and of course this situation happened. Well, I would have a lot of more things to show you, but I think Robert is ready to surgery, so if you need something, if you want to discuss that, we're going to have plenty of time during the lunch. Thank you so much.